All right. My name is David Ballot. Thank you very much for being here. This is an event sponsored by the Texas Public Policy Foundation. I am the director for the Right on Healthcare initiative with the foundation. Noel Collins is our policy analyst. Thank you for allowing us to be here today. I was really happy to see who the panelists were that were going to be here today. You've got some great minds that are up here on this stage, and I'm very pleased to be a part of this and to get to ask them really difficult questions. A little bit about me, my background. I'm a former hospital executive and CEO of nearly 20 years. Like Mr. Sinclair over there, third way down, I also ran for U.S. Congress. Unlike him, I lost gloriously in the primary, thankfully, but that catapulted me into the world of policy. And it's been very interesting, and it's been something that I've enjoyed, and hopefully you'll catch on to how passionate I am about this subject matter. Just as a way of setting the tone for today. You know, in the news, we hear a lot about the uninsured, the underinsured, Medicare, Medicaid. What do all those things have in common? They're not health care. They're health insurance. It pertains to the financial vehicle necessary, in many cases, to pay for health care. We have an absence of a discussion that is really related to the affordability of health care in this country. That's what we need to talk about, and that's what we're going to talk about today. When polled, the majority of Americans, what is the number one issue when it comes to healthcare? It's not about access. It's not about insurance matters. It's about the affordability of care, because it is expensive and it continues to get more expensive. So keep that in mind. Although, is it okay? I did threaten him earlier. Kyle Sinclair's running in District 20, and I said, look, one thing that I'm very frustrated with politicians is that they conflate the terms healthcare with health insurance. They talk about healthcare. We're going to fix healthcare. They're never talking about healthcare. They're talking about health insurance. So let's make a distinction. Let that be a trigger in your mind. Understand that when they're talking about healthcare, they're really talking about insurance. And then we need to really find a solution that will affect the services that we're receiving for the care that we need as a society. So with that, I would like to introduce our stellar group of guests here. I'm going to need to put these back on. To my left, Dr. Roger Moczygemba. Roger is the owner and physician at Direct Med Clinic here in San Antonio. Dr. Moczygemba he provides high-quality medical care through innovative delivery models. His direct primary care model, which you're going to learn more about here today, if you don't know about it already, his organization, Direct Med Clinic, solves the problem of access created by high premiums and high deductibles. He offers affordable access to health care for individuals and employers. He received his BA and MD from Texas A&M, and he received his master's degree in executive healthcare administration from Weber State University. Thank you for being here. To his left, we have Dr. Mizani. Did I pronounce your first name correctly? Dr. Mizani is the founder of South Texas Renal Care Group. He was recognized by Scene San Antonio as one of the area's best nephrologists. Dr. Mizani has centered his career on improving the health of the San Antonio community. His medical focus is on the generational effects of kidney disease, kidney transplants, chronic kidney disease. Why can I not say that word today? I can. I hope you can. Hypertension and diabetic management. He's a governor-appointed member of the Kidney Task Force of Texas to help enact meaningful kidney care policies. He received his MD at the Technology Institute of Santo Domingo and executive education and healthcare delivery models management at the Harvard Business School. He's also founder and chief executive of LASO Health, and I'm going to let him tell you more about that organization, because it is changing the way people purchase services in the healthcare space. I've already mentioned him a couple times now. Kyle Sinclair. He's a Master of Healthcare Administration. He's also a Chief Executive Officer at Warm Springs Hospital. He started in healthcare by obtaining a Bachelor of Science in Health Administration Service with a minor in Military Science from Weber State University. He graduated magna cum laude with his Master of Healthcare Administration from Ohio University. He has over 15 years of executive healthcare experience. He has an extensive background working within healthcare, ranging from operations, sales, and business development. And then, does anybody know this guy at the end? Let's give him a round of applause. Dr. David Vequist, known him for a while. He's become a friend. He's founder and director of the Center for Medical Tourism Research and vice president of Healthcare Standards Institute. He is a tenured full professor of management and the chair of management department in the HEB School of Business and Administration at the University of Incarnate Word. He's an accomplished speaker, author, researcher, and futurist on the topic of technology and healthcare trends, medical and retirement tourism, social media predictive analytics, and demographic trends. He received his BS at Northern Arizona University, his MBA at UTSA, and his master's and PhD at the University of Tulsa. Let's give him another round of applause. Thank you, gentlemen. Let's start this off with Dr. Moczygemba. First, tell us about what DPC is, but as a DPC physician, direct primary care, you've largely opted out of traditional insurance-centric models altogether while providing incredible value to both individuals and employers. Is what you do a niche kind of situation, or is that scalable? Is it a potential solution for our country?
So is that better? Can you hear me? Let me first just so everybody knows what direct primary care is.
Please.
So these days, insurance premiums are really high and deductibles are really high. So people don't have real affordable access to care. So in the DPC model, direct primary care, people pay a membership to the clinic, kind of like a gym membership. And then anytime they want to come in for an office visit or a virtual visit, it's free and it's unlimited. Just like you can go to the gym and it's unlimited. You can go and stay there for an hour and use a dozen different machines, and it doesn't cost you anything extra, as opposed to the fee-for-service world. In the traditional model with insurance, everything that's done in the doctor's office is a billable thing. And doctors look for those kind of things so they can get reimbursed more. So in the direct primary care model, we don't do that. People have their membership. They come in as many times as they want. They have access to us through virtual care, which is unlimited. And in our clinic, we give them a HIPAA compliant secure app that they can reach out to us with as well. So now your question was, is that scalable, right? Okay. Well, let me put it to you this way. Most DPC memberships are less than $100 a month. So is access to a primary care doctor for $100 a month, is that scalable? I mean, that's access to a doctor. It's unlimited access to a doctor. I think pretty much it is. Okay.
I appreciate that. Just as a follow-up, many people would say, well, the average panel for a primary care physician today is 2, 3, and sometimes 4,000 patients. For direct primary care, it's between 700 and 1,000. So you're seeing less patients. Certainly, would that be able to address the needs of more Americans throughout the country?
That's a great question. And I would like to answer it this way. Like, think of your experience when you go see your doctor who has 3,000 patients. How much time do you really have with the doctor? I mean, if you try to call the office, how accessible are you? Do they call you back? And how long does it take you to get in to see that doctor who's got several thousand patients? So in the direct primary care model, the access is affordable and it's there. I mean, most people, everybody in our office gets an appointment that day or the next day. And if they can't, then me or one of the other clinicians will reach out to them over the phone or through a video visit and take care of them. But so the point is, the access is there, and it's usually when people need it, right? The other thing I wanted to mention about the scalability of this is that people might be thinking, well, what if I have a higher level need than a primary care doc can handle? In our clinic, we've set the clinic up to even function as an urgent care.
And when you say that, you're saying, say they need a specialist.
Right.
That is, if they needed services that may be beyond the scope of their primary care doctor. Is that what you're talking about?
Yes, that's part of it.
Okay.
So one part is the urgent care or acute care, which imagine this: if you're dehydrated or you need a cut soda, we do that with no extra cost. We give people IV fluids, we give them pain shots, we give them antibiotic shots, all of that an urgent care would do, we do in our clinic as well. And then when it comes to specialists, so our goal is to keep our members away from the urgent care if they really don't need to go there, out of the urgent care, out of the emergency room. And then if they need a specialist, we subscribe to a service internally that gives us, as primary care doctors, access to specialists. We can go online and type up the case and send it to a nephrologist or a rheumatologist or whoever the specialist, a dermatologist, whatever. And then within a couple of hours, usually, we'll get a message back from that specialist that says, if this patient was in my office, this is what I would do. So we're keeping people from having to go to a specialist if they don't need to. And
you mentioned that you work not only with individuals who pay the membership, but also with employers. How is that working out? Are they seeing any benefit? And is this a benefit that their employees care for, that they're enjoying, and that they're seeing value in?
That's a great question. And so a couple of years ago, we had a relationship. We were doing some COVID testing for an employer in the Canyon Lake area. And so they were happy to have us do this testing for them. And the CEO began to notice that her employees weren't using the insurance that the company was buying for them. And she was scratching her head like, why aren't you guys using the insurance? And she found out it was because their deductible was too high. So we started explaining what we do and how we do it with that employer. And then the employer bought the memberships, and we had a broker involved, which made it ACA compliant. So now these employees have access to us with no copay. They have access to us through the app, texting. So they're using the care that's provided by the employer now. So this is a wonderful thing that employers definitely need to know about.
Great, thank you. So going from the local delivery of care, I want to move over to Dr. Vequist to look at a more global perspective. As part of your work, you study healthcare systems across the globe. What are some examples of ways that innovators are creating opportunities to make healthcare more affordable?
Excellent. I was a bit worried early in my career because when I was looking at places like India and Thailand and Korea, and even places that were people wouldn't consider a place to go for healthcare, places like Mexico, places like Turkey, we were seeing a lot of innovation throughout these countries, and people were starting to recognize that there was these options and there was potentially value in terms of lower cost care at a higher quality. But what I've seen, particularly over the past, say, 5 to 7, almost 10 years now in the United States, is just this wonderful explosion of innovation, which makes me very hopeful in the future. And if I can just give a small advertisement for this region, South and Central Texas. So we have some amazing things going on. I've been very impressed with what David Ballot and the Texas Public Policy Foundation is trying to do for public health by they bring crazy, wild people like me in to speak to state legislature and come up with really incredible models that are based on what actually works. We've seen for example, we brought up models that are working at Walmart where they're using their Center of Excellence direct bundled contract model to be able to reduce cost. Also, Walmart started with a second opinion model, which is helping to reduce costs by getting rid of unneeded care. And then, let's see, I'm trying to remember what some of the other things we talked about.
Dr. Vequist, while you're trying to think of it, for the audience that may not know, when you say innovation in healthcare, what does that mean?
Yeah, to me that means getting out of, my friend Tim has a statement that refers to the healthcare as this matrix that we all get caught in. And for too long in the United States, people have thought that there's only one way to do healthcare. And David spoke to it, it's this insurance model. And what we know from looking at both the innovation that's happening in the United States and internationally is that that's not the only way. Apple overnight became the largest healthcare information basically carrier in the world when they introduced the iWatch. Overnight, they just became. So just to go down this road. So I'm a student of history. Are you guys familiar in particularly let's go with country music. Are you familiar with outlaws and outlaw music in country? Okay, so you know the old original outlaws. I was reading this article about Aaron Lewis, formerly of Stained, and now a country western star, and they were saying he's an outlaw. So in South and Central Texas, this is the Texas outlaw healthcare group right here. This is the posse. What Dr. Moczygemba is doing, which is scalable, and we've run a capstone project for him and looked, there are ways in which he can take this to more and more employers, to take this through telemedicine, and be able to treat people in primary care, which is one of the biggest issues, and keep them out of emergency rooms at greater rates than ever before. So he's doing that here in San Antonio. It's not happening in Berkeley. It's not happening in New York. It's not happening wherever.
I tell my staff that's why we wear black scrubs.
There you go. Dr. Mizani, not only in terms of what he's doing here in San Antonio, treating patients, but has come up with this amazing piece of software, which is looking at incorporating things like value-based healthcare, potentially a second opinion, potentially getting employers, small and medium-sized employers that are not covered by the PPACA to be able to basically reduce the cost of their healthcare by giving access to their healthcare providers that are best for them. And if this model works, he's developed something that's going to become a unicorn. I mean, this piece of software is going to have billion-dollar valuation, and it's going to go crazy. Kyle is doing amazing things. The first day that he shows up in Congress, he's probably going to introduce suggestions to the Congress that could potentially reduce healthcare by reducing the tax burden to small employers that are trying to offer healthcare to their employees. Right here, just in South and Central Texas, we're not waiting for Silicon Valley. We're moving and we're shaking and we're creating things. So I've been just blown away by the talent and the innovation that's going on just in this region alone. Sorry, long answer.
No, well, I expected it. No, thank you for the answer. You said some interesting things. Depending on who you talk to, there are those that say that government needs to fix healthcare. There are others that say, well, we need to rely on the private market and insurance is going to fix healthcare. Those are two camps. There's typically a third, and those are the fellows those are the folks that typically are on, in the circles of those that are on this stage where they want to give control and information to the consumers. What would you say to those groups?
So pretty much every policy regulation that's been passed by federal government in terms of healthcare has been a substantial failure. When we look at what has worked in healthcare over the last couple of decades, it's been basically physicians, hospitals, working directly to offer patients what they need and what they want. Private healthcare tends to have overall better outcomes than public health entities. When we look at what you hear in the mainstream media, most of it is false, or I'll even throw out the term misinformation. So how many of you think that there are millions of medical bankruptcies in the United States? So you hear that on the news all the time, right? Well, guess what? That was actually done by Elizabeth Warren when she was at Harvard, and it's been rebuked by an article that came out in Health Affairs, which nobody knows about because it never gets past the mainstream media. One of the things they pointed out was it was self-report, and most of the people had additional types of debt, like house debt and car debt and credit card debt from drinking too many Starbucks. And so it turned out that wasn't the only type of debt they have, and that wasn't the only reason that they went into bankruptcy. In fact, most of those, like car and house debt, was actually higher than their medical debt. Here's the thing that they really topped it off with. The Health Affairs article then looked at the Canadian bankruptcy rates and U.S. bankruptcy rates. Guess what? They're about the same. There's no difference between bankruptcies in Canada and the United States. That's interesting, but there's big differences in the healthcare system, isn't there? So things like that in the mainstream media, we're not getting the whole message. So lastly, how about this? So how many of like Switzerland, Japan, give me your favorite healthcare country in the world, how many of those share hundreds of miles of a border with a third world developing country? How many of those, right? How many of those countries have populations that drive 10,000 miles a year in cars on average? And it's probably more than 10,000 years, right? 10,000 miles, sorry, in cars. But well, guess what? If you normalize accidents from automotive industries out of the population, our life expectancy rates are the same as they are in Japan. They're the same as they are in Switzerland. Those numbers are out there, and this research has been done. It's just the mainstream media doesn't pick up these things.
Yeah, thank you. One thing I wanted to add to the medical bankruptcies, of those that self-report being in bankruptcy because of medical debt, the majority of them have health insurance. I think that's always an important metric to make plain. I'd like to move over to you, Kyle. You're currently a CEO of a hospital here in the San Antonio market. And I miss being in the hospital, so I appreciate what it is that you do. But one thing that you've done that I have not done in a hospital is you ran it during a pandemic. Could you tell us a little bit about that experience?
Yeah, I mean, that was by far one of the most difficult situations I've ever been to. And I remember before I got into hospital administration, I remember talking to a very tenured CEO of a hospital, and I asked him, this was, late 90s, and I said, is healthcare still a good career to get into? And you saw a lot of changes coming in the late 90s and a lot of changes across the country. And he said, yes, that's when there's change is when you need good leadership. And it was interesting. And then now going through the worst pandemic that the world has seen in our lifetime, and hopefully we will never experience anything like this, it was difficult. COVID hit New York in November of 2019. It was the first patient that hit New York. It hit San Antonio March of 2020. That was our first patient in the hospital. My first employee got COVID March 27th of 2020. And from then we created a COVID unit, went everything from critical care intensivists to PAPR suits to innovation boxes to you name it. We went through the whole spectrum of wearing 1 mask, no mask, 3 masks, shield gowns. We went through everything. And you saw the transition of when government got involved, Metro Health got involved, and it was interesting watching government agencies come into what at that time was a deadly pandemic. In the beginning, it was very scary. We didn't know what caused it, where it came from. We didn't know how to stop it. We didn't know why it transmitted. We didn't know the origin of it. We didn't know a lot of things about COVID. It was very, very scary. And so when the city shut down, I'm working 16, 18 hours per day, getting up, trying to motivate my ICU nurses to continue to fight at the time, a deadly pandemic that we knew nothing about, working closely with critical care intensivists and infectious disease doctors through the Baptist health system and through my hospital. And we had massive ventilation capability. So it was a respiratory disease, and we became a COVID unit very, very fast in dealing with it. Started working with STRAC, the emergency management system here in San Antonio, by far one of the best in the state of Texas. It's the regional advisory committee that handles all natural disasters through the state of Texas, and ours is STRAC, is the South Texas Regional Advisory Committee. They did a phenomenal job in helping with products. That was one of the biggest things, and you saw the disease fell into the SNF origin, and they didn't have the training, they didn't have the resources, and you saw a lot of high deaths in those situations. But it was extremely scary. It was a difficult time living through COVID as a leader, as a hospital executive. Again, not being able to stay home when the city shut down and we didn't know anything about it. Going fast forward 2 years, now 3 years later, I have a different perspective of where it's at. But I will tell you that experience of seeing federal government, state government, and city government get involved in healthcare was one of the main reasons why I decided to run for Congress. We need people that understand healthcare, that understand bridging the gap between government agencies, the free market, working closely with physicians, understanding the hospital side of it, and understanding the flow of patients. And obviously, it's a business and understanding that side of the company. So,
yeah. And I just want to tell a quick story about what it's like in DC, because I work with a lot of offices federally and in the state of Texas and a few other states. When I first went on a trip, I was excited to talk about a subject that I love. And so I met with the healthcare experts. And their breadth of knowledge was impressive, but the depth was not very, very good. They didn't understand the subject matter in a deep way, so they couldn't speak to it. It's important for you all to know, perhaps, that the experts in those offices are the ones that advise and guide the elected officials on how to vote. Many of them don't even read some of the things that they're going to vote on. And how can they, in large part? But because there's so much of it. But you would expect them to have a working knowledge of the material, and many times that's just not the case. We expect different of you, should you win, sir. Hospital costs have escalated considerably. They always have, and right now we're seeing a spike upwards. I think here recently in the last year, it's been a 24%, which it's hard to conceive that because of how high they were already. Some of the numbers I've seen border on lunacy. One of the big arguments being made by the hospitals are that of staffing. Staffing has gotten to be such an issue, and help us understand that. You talk about the regulations, you talk about the stress, burnout, of course, is a big part of that. But is that really? Talk to me a little bit about that and how that really functions from your perspective, being in the hospital.
Absolutely, and I'll start kind of back what he said. I'm going to back up a little bit. So, to David's point, out of U.S. government, we have 100 senators, 50 per state, 435 members of representative in the House right now. So 535 members in U.S. government. There is one person who has hospital administration in U.S. government right now. One. You have some physicians, some pharmacists, some dentists, but only one person to actually run a healthcare business. That's a senator out of Florida. There's nobody in the House of Representatives. And so they lean on lobbyists who also have special interests and funding to go that way. So the healthcare community as a whole is not largely represented in U.S. government, and we spend 20% of our GDP on healthcare right now. And it doesn't matter what party affiliation, doesn't matter what race you are. You enter this world touching healthcare, you touch it all through your life, and you leave this world touching healthcare. It's a part of our life, whether we like it or not. And because of what these gentlemen and what TPPF is doing, it's a significant part that we've got to put more emphasis on. You know, back to your question about staffing is huge. During COVID, I mean, you had hospitals paying $50,000 bonuses. You had nurses that are making average about $75,000 or making $150,000. You had nurse practitioners quit doing nurse practitioner work to go back in the ICU level because of the amount of money that was being paid. That is still going on. It's got less, but the state of Texas was paying hundreds of millions of dollars on COVID relief staffing, and that pushed every industry to hire more, right? To offer bonuses and competing with hospital after hospital. And CNAs can make, you know, $14 an hour because McDonald's is paying that because they can get staffing. Now, every shift is going up. The cost is also going up. A lot of you don't realize with the economy the way it is, and one of the 50, you know, it's the 50-year worst economy we've had, that has impacted even our healthcare premiums. Those are going up 25%. You will pay 25% more for your healthcare premium right now because of the state of the economy of this country. Right now, we are going to pay more, and we're seeing it across the board. And so we've got to stabilize the economy. We've got to stabilize the staffing. I mean, the shift of COVID is definitely decreased. We're getting some type of normalcy, but the rates are still extremely high. It's the number one cost of any business is your labor force. And in healthcare, everybody's educated with a degree or specialty, and so their rates are even higher. So we've got to combat that. We've got to find that normalcy so we can get back to functioning as a healthcare system. And hospitals are no different than, you know, a mom and pop business that's running. The cost is up and it's extremely high.
Number one line item is staffing for payroll. Number two is supply, but staffing right now is far exceeding anything else in a hospital. Do you have hopes that those rates will normalize?
I do. I think you're seeing a huge shift right now. I mean, the military's pushing for healthcare people. You're seeing schools are offering it right now. You're seeing paramedics now using LVNs. You're seeing a lot of different initiatives. And that's the benefit of what happens during a pandemic. You get a lot of innovation, as we've been talking about. I mean, you're seeing even on the staffing side, people joining the industry because they know there's a shortage. There's a great opportunity to make good money. It's a great career. It's reliable. You don't have issues in regards to being laid off because you can find a job anywhere as a nurse or a therapist. So you're seeing a lot of increase with that. What was interesting during the pandemic is we were robbing Peter to pay Paul. So you had people leaving the hospitals to get these high contracts that would then put back into the same market they left at a higher rate. And you had your stable staff that had been there for years that weren't getting paid that, realizing what was going on. So you saw these crazy balances. I just took a leave of absence to finish my campaign, but right before I left, we were hitting shifts of my food service technicians, my CNAs, my EBS, house cleaning, and raising their rates to be competitive. Because again, as a CNA, you know, you're making $10 to $12 an hour, but you can go to McDonald's and make $14 an hour. Why would you stay? And so we've got to get competitive even with that level of market. But you know, that's a tough one because in healthcare we're all being cut. Medicare funds are being cut. Insurances are coming on; they're cut. So you're seeing a lot of push down from reimbursement and the rise of salaries increasing. The margin is shortened, and that's what happens when you push a business like that. It impacts all of us. And again, healthcare does not care who you are, when you are. You want the city to be there. San Antonio's healthcare is the second largest employer in the state, in the city of San Antonio, the industry itself. So it's a big business.
Thank you, sir. Dr. Mizani, I would like to nominate you as chief outlaw on the stage. All in favor? Congratulations.
Thank you.
Many of those in the medical industrial complex say it's just not possible to have transparent pricing in healthcare, particularly in the specialty areas. As a specialist, tell me, why did you feel it was necessary to start your company, LASO Health, and move the needle in making pricing available to everyone? And do you believe it's helped make services more competitive?
Definitely. So my story is very simple. I'm a practicing physician in San Antonio. Been here for about 20 years. Practice primarily in downtown Baptist, not far from here. In the emergency room, I used to see people show up with advanced illness that should have been evaluated, detected, treated earlier. They would not have been in that situation. Many of them had insurance, which was surprising to me because I thought, well, if you have insurance, you can get seen, be taken care of, and not show up half dead. But when you would talk to people, you would realize a lot of people are lost in the access of healthcare. How do you navigate when you have chest pain, shortness of breath, abdominal pain, and you have to also pay your rent, and you have to buy food? So not knowing the prices of what that will be, it just makes people delay care. So deferment of healthcare is critical because healthcare cost is a black hole. So with that saying, I don't want to say that medicine in America is bad. No, we have the greatest doctors, healthcare providers, research, medications worldwide. In fact, if you're diagnosed with a bad disease, this is where you want to be. But what is broken is the cost of healthcare. And that is what we're trying to fix. And that's a mission of our outlaw group here. That's why he's going to be winning the congressman, right, position. How do we pay for healthcare? I think people knowing the price of things will make it a lot easier for them to actually go and seek for it. And yes, have we achieved that in San Antonio? Yes, but if you get on LASO Health, it's an app, by the way, and also it's desktop, you will know what things cost, where they are, who are the doctors, what's their ranking, when can you see them. If I ask the folks here, can you book a trip right now to London and get a 4-star hotel with a car included? How many can do that right now within 60 seconds? Nobody else back there can do it? Come on, you know better than that. Well, let me ask you a question. How many of you can book a tooth extraction, know the price up front, and you want it done tomorrow within 5 miles of where you live? How many can do that? How about an MRI? Well, you do. I think there is a lack of health technology integration, price transparency, access to care in the United States. And that is by design.
I couldn't have said that better myself. Healthcare is unnecessarily complex, and that's intentional. What is healthcare? Healthcare is the relationship between doctor and patient. The reason why it's become so expensive, so inefficient, so frustrating is because there are a bunch of middlemen that saw a lot of money getting in between the two primary stakeholders. And there are a ton of them. And many of them have been regulated into that position by various levels of government. So we have a lot of work to do. I have a question for you, Dr. Mizani. People will say, doctors aren't going to offer a cash price up front. They're just not going to do it. But you're finding that to be untrue. How are the medical professionals in San Antonio and everywhere else that you operate, how are they responding to your efforts?
Pretty much 90% of doctors that we talk to, first we have to explain to them what it is that we're trying to achieve. Once we explain that and they realize, okay, wait a minute, if I put a price up front, I know that's what I'm going to receive, and I don't really have to spend 90 days to file claims and have multiple billers, collectors, refusal from insurance company to pay. Well, I can lower my prices because it's one price, and I will receive those funds within 24 hours of healthcare delivery. We are trying to remove all the intermediary and basically have the patient and the doctor or the dentist or the laboratory, company that performs that test know exactly what the price is and location where you want it done. There's nothing else in the middle. Now, can we replace health insurance? The answer is no. Health insurance, in terms of catastrophic health coverage, should always be there. Car accidents, cancer, chronic illnesses, kidney failure, kidney transplant. But do you know the majority of us in this room, we will never hit our deductible. So in 1 year, as you know, you have health insurance that has a deductible of $3,000, $6,000, $9,000, depending on what that is. Almost 80% of Americans never meet it. Tim has a nice sentence that works with us in LASO. He's actually the CEO. If in the bank you have less money, savings, than your premium, than your deductible, you're not insured. In other words, if your deductible is $9,000 and in the bank you have less than $9,000, you're categorically uninsured because you don't have those funds to pay. So bankruptcies, medical bankruptcies, all those are true. And it's just because the program is flawed.
And let me just drill down on some of those numbers. The average family of four in this country spends $22,000 a year on health insurance premiums. Many times that's shared with your employer, but that's what it is for a family of four. $22,000 a year to get your insurance card. Now that's the equivalent of a VW Jetta every single year. Whether you want to buy a VW Jetta, that's not what I'm talking about. It's a new car every single year. Now, again, that just gives you the card. Now you have a deductible. And the average deductible is, I'll give you a range. It's between $4,000 and $6,000 per person. Family is typically twice that number. Okay, well, 60% of Americans don't have $1,000 in their bank account. So it might as well be monopoly money. We have a real issue. Insurance isn't functioning in the role that it's intended to. And I think that's what you were getting to the point. Is it necessary? Absolutely. And for most of the people in this room, you may not remember, or you may not have really looked into it. There's something called an HSA card and a health savings account. And what's interesting about this piece of law is that it talks about having a high deductible health plan. When they first started it, you know how much a high deductible was? $1,500. Today we're looking at an average range of $4,000 to $6,000. Healthcare has gotten precipitously more expensive in every single arena, with the exception of some of the things that we're talking about here today on stage. I want to talk about, and this is, I'm opening it up to just about everybody now, so chime in if you have a soapbox under your chair. Let's see, I'm trying to remember. January of 2021, there was an executive order at the federal level that was mandated across the country for hospital price transparency. Hospitals had to disclose their pricing on a website. In the state of Texas, we brought that executive order and we codified it into law here in the state of Texas. It's now Texas law as well. There are some organizations that are doing research to see if if the hospitals nationally and in the state of Texas are complying with those laws. Their assessment is that only 14% of hospitals are complying. I'd love for you gentlemen to talk about that law. Is it helpful? Is it hurting? Is it something that's going to be a first step in further developments? Share with me what your thoughts are on that issue and how it can help.
So what's interesting from a transparency standpoint is most of the large, for example, academic medical centers in the United States have been doing that for decades now for foreign nationals. So if a wealthy foreign Saudi patient comes to MD Anderson, they've been telling them up front what those costs are. So the free market always encourages, if not mandates, transparency. So whenever you see free markets expanding in healthcare, you see the expansion of free markets. So it's like a force of nature, regardless of governmental regulations, which I'm in favor of this particular one, but it was going to happen anyways, because as the free markets start to, again, intertwine themselves in these healthcare interactions between consumers and healthcare facilities, you were going to see more and more of this. Even in, so I'll give you an odd area. So this is industry fund, and David's very talkative about PBMs on LinkedIn, for example, talking about how much damage that they've done, and that they were started to do something good, but have turned out to be the enemy, essentially, in terms of increasing costs of healthcare. So another innovator, we're talking about the outlaws. So we got an innovator, Armando Blanco, sitting here in San Antonio. He's been pushing for many years to help companies all around the country to basically get lower cost access to pharmaceuticals. Most people don't realize that, and actually was it in Belgium? I think it was Belgium diplomat accidentally released records, and it showed that basically the U.S. was paying a higher price for the COVID vaccines than every other country. You guys know that happens for all our pharmaceuticals. The reason why the U.S. pays a higher price is we basically pay for the development because it can't be paid for from developing countries in Africa and Southeast Asia and places like that. So we've always paid higher prices. So Armando was like, well, that doesn't have to be the case for everybody. So he started finding a way where we could get access to pharmaceuticals from Canada that aren't paying the higher price and basically get them even mail ordered into the United States for employment. So there's ways to do this, but it's embracing the free market and free market principles, as we've heard from some of these gentlemen.
I have, hold on to that mic. Sure. You said something that is pretty important. You made a distinction between the prices being shown to Americans versus Saudis, but you referred to the foreign nationals being a part of a free market system. Are you saying that we don't have a free market system in this country?
I think it was pretty clear from what we've been hearing that, that we're the outlaws. I mean, we truly are. We're trying to break out of the matrix. And these innovators, and again, you would think most people around the country thinks that this needs to be coming out of Silicon Valley, right? Well, it isn't. It's coming out of people that are doing this work in South and Central Texas, and we're basically embracing free market principles and finding ways to break through healthcare and get past all these this regulatory mismatch and all these problems and issues of middlemen that they're clogging up the system. And if we can do that, healthcare is going to be better for everyone. It's going to be better in terms of cost. And we're also going to be able to be choosier in terms of the quality that we provide. And by the way, just a real quick advertisement. That's a uniquely American idea. Dr. Porter from Harvard, value-based healthcare. That's a uniquely American idea. It's actually being embraced all around the world. It's one of the fastest trends worldwide. And it was produced here in the United States. Well, why don't we use it ourselves to actually make sure that we have a better healthcare system in the U.S.?
So I just want to say, if I can, I grew up here in this wonderful country, and I thought always that we're in a free market society. But a few years ago, I had a realization that we don't have a free market in healthcare.
Amen.
And so I started with co-founder Sinclair the San Antonio chapter of the Free Market Medical Association. And so we've been doing this for about 3 years now, and it's always been our goal to create a free market in healthcare in San Antonio. And every time we get together, I beat the drum of what we're trying to do is bring together doctors, clinicians like Dr. Mizani, he's participated with us and still does, and other facilities, hospitals, and bring doctors and healthcare providers together with employers who pay for healthcare, the majority in this country, get those two groups together and a few brokers that can help, that want to help. And with that, we can create a free market healthcare community in San Antonio. And if anybody is listening to me, we would love your help and support in doing that. We meet every month or every other month. We have a meeting coming up November the 3rd. We would love for you to get involved with us and help us grow this community, because a rising tide raises all ships. It's always been our mission to do that. So sanantoniofmma.org is where you can find more information about that. Please come and get involved with us.
I think Kyle, and then
Yeah,
come to you, Dr.
sure.
Mizani.
No, I mean, what I was going to share, I mean, from the operation standpoint, every business is just like human nature, right? When the cost of something goes up, we change our behavior. When we're reduced price on something, we change our behavior, and healthcare is the same way. So in regards to that law came out, hospitals didn't jump on board of 14% because the penalty was insignificant. It was so insignificant to the bottom line, the behavior did not change. And you saw with ACO, or Accountable Care Organization, they did PACA, which is the pioneer, for about 3 years. And then they did a full-blown cut across the board. And when you started hitting the pocketbooks of hospitals, millions upon millions of dollars per month, guess what they did? They changed their behavior. And so we see it. I've been in multiple industries in healthcare. Anytime the regulatory changes in regards to how we're reimbursed, guess what we do? We change our behavior. And I've talked to President Trump's team who actually put that law into place and was talking to them about that. It's interesting. And they had to push it to get the small deduction or penalty to get it passed. And so it's interesting what's going on. And there are people that are trying to push on that. We've got to fix the price transparency. I'm personally fighting one with my son where I don't know how all of a sudden I got a $6,000 bill. And so we've got to figure out the price, and the best way to do it is that. I'm not advocating for heavy penalties in hospitals. For those who are recording that, I'm not advocating for that. But what I'm saying is we as human nature and as business, we change our behavior based off of how we're reimbursed.
For the record, I am. The first penalty at the federal level, it's increased. It was originally $109,500. That's a surgery. That's one surgery. So it really wasn't an issue. President Biden came in, and they really doubled down, and now the top penalty is $2 million. In the state of Texas, it's potentially tens of millions of dollars, but it's just a matter of whether the agency is going to enforce. Dr. Mizani.
Yeah, I was actually going to talk about the enforcement of that law. So, why hospitals don't disclose the prices? Very simple. They have a different price list for different insurance companies. In other words, they may bill $10,000 for X procedure to Aetna, and they may do it $9,000 for United, and different price for Cigna, and so forth. Medicare is the same. So you take that away from them, then they cannot negotiate prices with insurance companies. That's why they don't want to disclose. Also, they don't want to disclose within the same city that if you get a gallbladder removed in Downtown Baptist, the price is different than if you do it in University Hospital. University Hospital is actually twice the price. So as a consumer of healthcare, as a patient, you need to know what things cost and where. So I really urge people to, if you get a chance, download LASO Health, just for yourself. I'm not trying to market, advertise here, and I want you to see prices.
How do you spell it?
LASO, LASO Health. And you will see that this particular app is a sort of a platform where any healthcare industry, be it a doctor's office, laboratory, x-ray imaging, will come on, even hospitals, urgent cares, and list their prices, price transparency, so that you as a consumer will choose if you want to do that service or not. And if you did, there's no other $6,000 bills coming your way in the mail. It's done. It's one price. I think we need entrepreneurship in the health tech department. And, this is business school, so I suppose there's a lot of folks interested in the area. Get involved. There is significant lack of health IT in our field. We have a bunch of MRI CAT scans. We have antibodies now that can target a single receptor inside of pancreatic cells. Immunology is changing healthcare. We cannot book an MRI a block away from our house right now and know the price. So cost and reimbursement of healthcare is a problem. It's not medicine. Medicine is a lovely field. I was just seeing patients and ran over to do this today. You can change people's lives. Really, you can. But how they pay for it, how it will affect their family is the key. And I think together we can change that.
Guys, thank you. This has been great. We're going to open it up for questions and answers. Are you prepared for this? This looks like a rowdy group. Are there any questions in the audience? Gentlemen, two gentlemen in the back, and then we'll come towards the front. We have a mic.
Take this one. Let me take this one.
We'll share.
Thank you. All right. Which one? Who did you point to?
The gentleman over here, black, blue shirt. What color is your shirt? Black.
Thank you. Thank you for coming, by the way. I had a kind of a two-part question. With Kyle first, you briefly talked about COVID, because I virtually hear nothing on the news about it as far as where it's at right now. Do you, because is it like still here to stay, or where's everything going right now with COVID? Because I don't hear virtually anything on the news as far as like what's going on with it. Yeah. And also, the other part of the question was Affordable Care Act. Do you see it here to stay, or major policy changes in it?
Yeah, I mean, I would say from my standpoint, I can tell you, but physicians would definitely be the better answer. You know, the numbers when I was watching COVID and living through it, I watched one number. That was it. I didn't watch the news. I didn't watch the state numbers. I watched one number, and that was hospitalized patient. You can't fake a patient in a bed at all. And so that was the only number I followed entire COVID. And through STRAC was able to see when we hit our highest point of over 1,800 hospitalized patients, and we had no beds, we had no staff, and that's where it was. I mean, last number I saw, we're hitting 30s, maybe 40s, hospitalized. I don't know, you're in the hospital a lot more than I am. But, I mean, it's almost irrelevant. You know, my view, in my opinion, I think it's going to be just like the flu and the flu shot. This is a virus that has become less lethal and continues to mutate. And that's why we can't stop it. That's why the vaccine is not a vaccine. It has not eradicated the disease, like measles, mumps, TB, polio, and you name it. Those have eradicated disease. I support the COVID vaccine. I think if you're heading towards hospitalization or death, it actually could and can help prevent some of that. But I do not think it is as significant where it is right now. It is not a deadly pandemic, at least in the United States, in my opinion on that. So we're not seeing it. But unfortunately, I believe that just like the flu shot in the healthcare industry, it will be mandated. And it did come down through the Supreme Court that every entity who took Medicare dollars or Medicaid dollars, which is 99.9% of every healthcare, that you had to force people to get the COVID vaccine. So it's kind of an interesting dialogue where we're as a country and we're as a healthcare entity. So I don't know if I answered your question.
He asked about the ACA. Was it here to stay as well?
Yeah, I think that was that more for me? Or?
I'm happy to answer that. Yeah, no, it went to the Supreme Court. They established it as law of the land. So it's going to be an established program of the federal government, but it's insurance. It's not healthcare. So we're still seeing the same problems. Premiums are going up. The average deductible is $4,000 or so, which for people who are below the level of federal poverty line, is that something they can afford? So we want to focus on the affordability of healthcare for everyone. But yeah, no, it's a part of the fabric of the U.S. now.
And I would add to that, I think free market is definitely the answer. In my opinion, even though I'm running for a government position, government does not solve the answer. And if you look at the history of what the government's involved in, it's broken. In almost every sector that they're in, and they have complete control, it's broken. In healthcare, we do not want complete control from the government taking over healthcare. You need free innovation and free marketing, people that are actually working in the industry that have the phenomenal ideas that will help this country when it comes to healthcare.
Rob, the gentleman over there in the blue shirt had a question. I got that right that time. That is blue. So, it's green. 0 for 2. I need to see a doctor.
This is for Dr. Moczygemba because I work in the ER, and 99% of the time the people that come to the ER, the doctor goes, "Why are you here? You're not dying. Go to your PCP after you run all your tests, after they get blood work done, a CT scan." So when a patient comes to you that's healthy with no prior medical history, and they say, "I've had abdominal pain for 3 weeks," how does most of the fight to just get to know what's going on with them is hung up with diagnostic costs. So how does that $100 a month account for the doctor's visit, the diagnostic costs, like CT, or just any imaging, blood work, any lab tests, and then into treatment? How does that $100 a month cover all of that?
That's a great question.
That's a great question, and thank you for asking that. So I think part of it boils down to some basic principles, and the number one basic principle is access to a doctor. Okay, the other basic principle is what we're taught in medical school is that most of the diagnosis is made by taking a history from the patient. And then we back that up with our physical exam. And then after that, to confirm our impression after the history and physical, then we get diagnostic tests. And so in our DPC model, if somebody comes in with abdominal pain, we have time to get a good history. Most of our appointments are booked at 30 minutes for existing patients. So we have time to talk to them, get a good history, do an exam. And now if you came in and you needed imaging, we have cash pricing, we have contracts for cash pricing for imaging all around the city. So I could tell you in the office at that moment how much it's going to cost you to get a CT scan if I need to rule out appendicitis in that moment. And you can actually pay us in my clinic. We send you to, and it's affordable. It's a fraction of what you would pay if you had insurance.
What would a CT in the abdomen be?
Oh, Deborah, do you remember?
If you look at the LASO app right now,
Okay.
you'll see $275.
Pull it up.
Free market.
Okay,
No,
$220.
$220 cash.
Okay, so we will. Thank you. Perfect. So we send you for the imaging, and we get the results back that day. You don't have to go to the emergency room. So I hope that answered your question.
And can I take it a little further? All right. Let me ask you a question. You guys probably have Netflix. What if I told you by the beginning of this coming year, for a price of Netflix monthly premium, you will have free, unlimited, no copay, no payment access to a physician via telemedicine in the United States. Do you like that? So healthcare will evolve and change, and it's going to be basically depending on all of us coming up with different solutions. Some locally, because you need to see Dr. Moczygemba so he can put his hand on your abdomen and examine you, or me, listen to your lungs. But there is so much that can be done with an access to telemedicine 24 hours, 7 days a week that we forget. That includes psychiatry, mental health, teen therapy, talking, and getting a prescription for your urine infection or your suspected pneumonia. All of that will happen, and obviously we'll launch it and let everybody know.
Can I ask something real fast?
Yes, and then this gentleman here will have the
I
next
think
question.
the benefit of COVID is you saw telemedicine found its place in healthcare. It was not reimbursed prior to it. It was not adopted by most physicians. You never saw it as a mainstream part of their practice until COVID, until patients didn't have access to hospitals or physicians, whether by choice or couldn't get there. And that created this scenario where now you're seeing it's reimbursable for their time. It's a benefit, and you're seeing massive amount of advance in healthcare. So there's a huge benefit that came out of COVID is the placement of telemedicine in healthcare in the United States.
Which was restricted by government policy.
That's
It was
exactly.
restricted by government policy. So just like almost all the other problems we've seen in healthcare, it was government getting involved because there was money to be made to be able to restrict healthcare in some way, or to route it through a particular group or individuals that make money on the stock market.
We're coming back around the horn, Dr.
Yeah.
Roger. See what you did?
Just to take that further, the way that we are reforming healthcare up here, it's starting in the room between the doctor and the patient, and that's the way healthcare needs to be reformed from the bottom up, and that's really the definition of value-based care. It starts in the room. I mean, think about it. When you go see the doctor, you don't want a third party in the room with you. And the third party is the government or it's the insurance company. So if we can keep this momentum building, we can literally reform healthcare. That's what we're here to talk about, right, David? So we can do that from the ground up. It starts at this level. And it's our goal to do the best that we can as doctors, use the technology that's available, and be an example to everybody else on how healthcare should be delivered.
To add one more thing, COVID was a bad thing that happened to humanity. Millions got sick, thousands died in this country. There are people in this room whose friend died from COVID. But it brought so much innovation and understanding on how we approach disease process as physician and healthcare delivery, and one of them that convinced the government to allow telemedicine is it's COVID, right? I mean, with COVID, they allowed to do what we've been asking for years. It was impossible for us to do a telemedicine visit because it depended on where the patient is located and where you located. Can you believe that? In other words, the law had said the patient had to be in where they could not come to see you as a doctor. What difference does it make? You have single moms or dads working. They can't leave their job to go and sit in a doctor's reception office for 2 hours, but they have a ear infection or toothache. So with catastrophe in humanity, innovation gets born. And I think that's the thing for you to take home.
Thank you. Excellent question, sir.
Well, first of all, I applaud you, gentlemen, for your innovation. Reform always comes from a populist movement. You have to start at the bottom, and everybody has to get involved in it. My situation is I'm both a veteran and a retiree, so I deal with both bureaucracies. I deal with Medicare and the VA, and it can be very frustrating to do that. So there's some other things in there about streamlining, between the different entities and whatnot. I've been researching all this stuff for a long time myself, and there's just lots of disconnection in it. And one of the things that I found out is a lot of the cost is due to administration. I'm sure you're familiar with that as a hospital CEO. So my question right now is, we're in hyperinflation. There's no doubt about it. That's driving up the cost. You're talking about the free market economy. We're not in a free market economy right now on any level. When you start destroying your energy production and whatnot, that's the baseline for it. Where do we get our energy? So we're kind of in a war right now over that one particular resource. So there's lots of factors that are involved here that need to be done, but it is a populist movement in all sectors, not just the healthcare industry, but in all the what they call the 7 mountains: education, government, religious, or whatever.
Pardon me, sir, just for the sake of time.
What's your
Did
question?
you have a question?
Well, my question is, we have a lot of people that kind of fall through the cracks on this stuff. Because like you just said, there are people, single parents, trying to cover their health care costs and all these things, and the wages aren't keeping up with it. So I like your thing about your LASO and also your DCP. But we see a lot of people got hurt from COVID. They lost their jobs, they lost their businesses and all that kind of stuff. So we still got a recovery period there.
Who'd like to take that?
Yeah, so I've got just a couple comments on it. So one of the things that we're seeing is there is people that are challenging this matrix. For example, I mentioned the Walmart model earlier. People that are making whatever the minimum wage Walmart is paying are getting access to some of the best providers on the planet, which many of them happen to exist here in the United States, because they have these direct bundled contracts. So Walmart's saying to a cashier that may have a child that has a rare form of cancer, you can go and see the best specialists on the planet at the Cleveland Clinic or Mayo or MD Anderson or where have you, and we'll pay for that. And that's through a direct bundle contract where they have negotiated directly with the hospital and the physicians to get a certain cash price, if you will, for their employees. And so this is innovation that's been around for over a decade that has existed. It's called in the research sometimes domestic medical tourism because they typically travel within the country. Here in town, we have an entrepreneur, Trudy Maiden, that is using her clinical trials company to actually develop a primary care alternative for people that are very low income, perhaps don't have access to health care, and they can come in for free checkups and get some primary care while getting involved potentially in clinical trials. So that there's some amazing innovation, and I think your point is well taken, that if you look at the VA, you look at Medicare, Medicaid, you look at some of these governmental programs, you're going to see for the most part that they don't offer the value that people are seeking. They don't offer the, just look at the Oregon Medicaid experiment and you see that basically you can offer people these government programs, but they don't get better. Their health outcomes don't get better. So the only change you're going to see is from people that are willing to be outlaws. And that's these private businesses, particularly self-insured businesses, and entrepreneurs and innovators like we have up here.
When you talk about people falling through the cracks, I think of our Medicaid population. They struggle to have affordable access to a doctor. But what if our policymakers and legislators could make a program available to them, kind of like an HSA, and give them $100 a month, for example, and say, here, take this voucher and go find a DPC doctor. Well, with that, do you think that would be scalable? I guarantee you we would see DPC doctors pop up everywhere. And these people that are now struggling would now have unlimited access to a doctor early on. So they could be seen when they're sick and not have to wait until they have to go to the emergency room or get admitted to the hospital. They could get their diabetes controlled so easily.
Or have to find transportation or childcare. They can do it from the phone. Rafa, young lady in the back. Raise your hand.
Black shirt.
Black shirt, thank you. It really is black this time.
Hi guys. I just like to say I'm an international student from Portugal. I grew up in a country that doesn't really know what paying for healthcare is.
It's hard to hear.
I'm from Portugal. I grew up in a country that doesn't really know what paying for healthcare is. You mentioned $109,000 as a penalty cost for the hospitals. And you also mentioned, oh, that's a surgery. What I thought was people in my country don't make that in 10 years, which was unbelievable. It's just unthinkable. My first encounter with healthcare, American healthcare here, I ended up in the ER, and my copay, which I thought I had a pretty good insurance, I ended up paying $500. And in the space of like 2 hours, I saw 5 different people to whom I had to say the exact same thing 5 times. In your opinion, do you really believe that reform is possible? And do you think this will happen in a future that we're all still here for? I think that's the most important question.
So, I wish you would have known LASO app by then, but now you know. A surgery depends what type of surgery we're talking about and who gets those funds. Okay, so just to give you an example, a cardiac heart bypass surgery, 3-vessel or 4-vessel, which is one of the most complex surgeries a human can get, the doctor gets $1,800 and for 90 days has to see that patient. In other words, there's no other additional income that the physician who performs the procedure gets. the reason why healthcare potentially is so expensive in this country is because everything that is healthcare related labeled, from the chair that you sit on, that is medical grade, to the syringe that they put in you, has layers of people that change hands and they mark up and they make it so expensive so that the delivery at the end is such. So, yes, our hope is that in the near future, if we have right people in the government, more of them, and us talking together and coming up with different solutions, we can come up with multiple options so people can choose from, right? And a high deductible ACA plan does not solve the problem, because if you don't have $9,000, $6,000 to pay for that, you're unfunded, right? Unless if you were admitted to a hospital and that they diagnosed something bad that your insurance kicked in after $9,000, then the insurance coverage begins. So the other thing in healthcare we didn't talk about today is that litigations.
Yeah.
So medical legal aspect of healthcare make it so that you see 5 people and you say the same thing 5 times so they can document it 5 times. So if there is a lawsuit later on down the road from you, they could go and see if you really had mentioned this or that, or they missed something in documentation. So the time that we spend with a patient potentially in a room is 7 minutes as a doctor nationally. Do you know how long we spent outside the room documenting what happened and went on and so on? Another 10 minutes. So bureaucracy in terms of documenting things over and over adds to the cost of healthcare. And patients, instead of spending the time with a doctor that they can tell them what's going on and we can diagnose what's wrong, it gets sort of changed to just filling up paperwork. So it's multi-layered.
We're up on time. I'm sorry. Let's just take one more question. You had your hand up first, ma'am. And after the question and the answers, we will stick around for any more discussion, if that's possible.
Yeah, I had a question over there. We'll stay around.
Okay, we'll stick around. I apologize, but just out of courtesy to everybody else, we want to end a little late. My apologies for that. That's my fault. Yes, ma'am.
I want to talk just for a second about how where care is delivered is so important in the price. Dr. Moczygemba, you know that I review claims for a living, and so I see prices for all kinds of things, low, high, middle. A very common test is something called a complete metabolic panel. And I reviewed claims for a client of mine, and there is a hospital system, Mr. Sinclair, it's not yours, that was paid $1,680.77 for that test 33 times in 1 year. Average insurance payment for that test is in the $80 range, depending on where it's delivered. What do you charge for that test?
That charge is listed on our website because we're transparent. It's directmedclinic.com. It's $2.50.
Yes, and just so that you can cover your costs, you do cover a draw fee for that, right?
Yes.
And you charge one draw fee.
One draw fee
for however many tests you do.
Right.
Okay, I think that is a great example of for an everyday person, what the difference in things cost. Thank you.
Great for pointing that out.
Thank you. Just real quickly. So one other thing I'd like to point out, employers have the same problems. So that's why the University Incarnate Word, this campus that you're on, a couple of years back, we said, you know what, we're sick of paying these prices. So we went self-insured. And so we're now self-insured. We're a small employer compared to a Walmart, but we're self-insured. And it's one of the fastest growing trends in employer health right now is to go self-insured, which allows them creativity to take care of their employees and be able to find new and innovative ways to offer healthcare. And just for Marta, who just left, also wanted to point out that for those of you that don't forget, when you pay taxes, for example, if you're in one of the Nordic countries, you're paying 75% of your total income in taxes. That is paying for healthcare. So in the United States, we're total tax about 50%. So Basically, take 25% of your total income, total household income. That's what you're paying for taxes when you go to places like Europe. So don't forget, government healthcare, not necessarily always good.
I apologize.
Yes.
Before you lose this crowd, these are the Texas outlaws here.
Yes.
I assume in the state there are more.
Yes.
So speak to that, but also let us know as consumers what we need to be doing to help the outlaws get their message out there.
I think we need shirts.
Sure.
Black ones, but you guys pick the color. 'Cause I'm not doing it. An organization that I started, Free to Care, which is a coalition that deals with things on a national basis. We started a trade group here in the state of Texas called Direct Care Texas, and it's directcaretexas.com, and we're basically identifying all of these practices and facilities that are transparent. So we're trying to make people more aware. Thank you guys for coming. I'm sorry we're running long.
But he doesn't matter. It's okay.
Anybody else? You guys have anything to say about that? Of course, LASO.
So, Dr. Vequist, yes. What are you going to do for a living when we're done?
Oh, so I love being a disruptor. I mean, real quickly, I used to be a hospital executive. Also used to be a consultant. Went into academia for work-life balance. Best thing in the world, except for being a rock star, professional athlete, or maybe a YouTube influencer or something like that. But I just get to sit around all day and think about healthcare and think about ways to basically break things and make it better. Because the system we have, both in the United States and many places around the world, is broken. David touched on most of those, and he's very well aware, one of the smartest people I know in healthcare. And we need more people that will go and change things, both at the government level. We need entrepreneurs and innovators, and we need people that truly care for their patients. These wonderful, amazing DPC practices. So there are things happening. I get to sit back and watch it, help a little bit, dabble occasionally, and it's a great life. So thank you.
No more medical tourism.
Medical tourism is just part of consumerization of healthcare. As people are traveling, whether it's across county lines, state lines, international lines, people are traveling for healthcare, and God bless them. So they find what you want, get what you want, do what you want. It's your healthcare. So
being that we are on a college campus, there's now a quiz. By a show of raised hands, did you learn something new today that you didn't know before? Outstanding. Good job, guys. Now the more important question. Did you have fun?
Yes.
That's not any hands. Yes. You should be so disappointed in yourself. Thank you very much for being here. Thank you guys. Round of applause for the panel.
thank you for coming to UIW today. Thank you.